Okay, thank you very much. Assalamu alaikum, all the dear students. Today our class is regarding the completion of the concept of our clearance. In the concept of clearance, we have already understand the different areas, its definition, its methods of determination, and then we move towards the clearance about the examples in the tank and faucet analogy. Then we calculate its units, and now at the end we use the concept of the creatinine clearance, how the creatinine clearance help us to adjust the dose. We made 2 or 3 different labs, and having our concept regarding the dose adjustment where the patient's creatinine clearance is not normal and uremic patient especially, and then we calculate it. Okay, today we will check is there any type of the relationship between the clearance relationship between clearance volume of distribution and half-life. The topic of our concern is there any type of the relationship between the clearance and the half-life? If yes, then how it will affect the dose of the drug and how we have to adjust the dose of the drug. Either the clearance is compromised and now half-life will also have some effect, and after getting this type of the effect we will change the dose of the drug. Simple answer is, so the formula is simple, clearance is equal to KVD. Now we can see clearance is directly proportional to the volume of distribution. Okay, when we discuss the one compartment model and we have the concept of rate constant K, and this K is 0.693 over T half. So T half is 0.693 over K. And we can write the value of this T half, the value of K here. Okay, and we will get clearance is equal to 0.693 over T half into VD. So according to this equation, we can assume that the clearance is directly proportional to the volume of distribution. Is there any type of the change? Then we can assume that the volume of distribution of the drug is also changed. But in our other concept is volume distribution is a constant for the different drugs. So we can assume that the maximum, when we have the clearance, we have the change in the concentration of drug with respect to time, which is irreversible. Then we can assume that there will be the change in the volume of distribution also. Okay, what about the half-life? In case of half-life, we assume that giving us the inverse relation. If we have the maximum clearance, then we can assume that the relation with the half-life will be increased. Creatinine clearance decrease, half-life will be increased. We will have to understand this concept with very simple concept. If the drug kidney is not working properly, then we will assume that drug is not getting cleared from the plasma irreversibly in a unit time. So we can assume that drug is present in the systemic circulation, and when the maximum drug is present in the systemic circulation, then we can assume that the time at which half of the drug will be eliminated from the body, which is actually the half-life, will be prolonged. So we can assume that if the clearance is reduced, half-life will be increased, and in the vice versa. If the clearance is high, then the half-life will be low. So in this type of the example will give us the actual concept of the different drugs, and we can calculate the dose of this type of the clearance, and we use of this type of the concept by calculating the dose adjustment of the drugs. Okay, how can we see the concept of this dose adjustment regarding the half-life by using the concept of half-life. The same with the which we have already clear the concept of rate of change of drug in uremic patient divided by the rate of drug change in the normal patient, that was equal in the dose of the normal patient, dose of the uremic patient over dose of the normal patient. And in case of dose interval, we have found that was the inverse. Why that was inverse? Because we got the maximum dosage interval when we assume that the different concentrations. Say there was the creatinine clearance of the uremic patient divided by creatinine clearance of the normal patient, and we have we can calculate this ratio by using the nomogram. And also we have already performed in our previous labs when we discussed the fraction of the drug, where we already found this type of the Ku over Kn. If we have this Ku over Kn, then we can assume that we have the T half over T half. This T half is for the normal and for the uremic patient. Remember, this is just like a dose interval. When we want to check, okay, we know this ratio and we have the normal T half, then we can check the uremic T half. This will give us the concept of the change in the concentration of T half. T half means half-life will be changed, will be increased when we get the decrease in this type of the ratio. For example, if we have a drug whose Ku over Kn ratio, which is actually fraction of drug excreted unchanged, then we can assume that this ratio will give us the concept of this type of the same. So when we move towards our actual concept of the calculation of these type of the doses, the half-life, then we can make an equation. This equation is just like Ku over Kn Ku over Kn is equal to 1 minus fraction of drug excreted from unchanged clearance creatinine over clearance uremic. It's uremic clearance or it's normal. This will give us the concept of Ku over Kn. And this Ku over Kn we can also calculate by the nomogram. When we check the Ku over Kn, we will coincide the same value with the half-life concept, and then getting the half-life concept we will take its inverse, and taking the inverse of this Ku over Kn will give us the inverse of this T half over Tn. Then we can have the concept of the dose adjustment for the uremic patients. What we are saying? We are saying that we have to calculate this first, then divide with this Ku over Kn. That will give us the concept of T half normal over T half uremic. This will give us, this concept is actually, because we know this T half uremic over T half normal is equal to Ku over Kn. Now we want to check this, inverse this one, then we have to multiply with this. So we will calculate first Ku over Kn by using this equation, and by getting this equation we will check the half-life area. When we have the half-life, different concepts, then we can check the, okay, is there any type of the what type of the change of the half-life is. We will have to take example. For example, in case of table 224.6 in Lyon-Shargel, we have plenty of number of drugs having their different half-lives. We will discuss the simple drug of the, say, erythromycin. In case of erythromycin, they have given us the normal half-life is 1.1 to 3.5. So, okay, so we assume that half-life of the erythromycin is 2 hours. This is our normal half-life. This one, normal half-life. Okay, what we want to calculate? we want to calculate the half-life of those patients who are uremic. And who are uremic in which sense? Having the less creatinine clearance, 10 ml per minute, 20 ml per minute, and 30 ml per minute. Then we write the T half 2 here, and then we will check the what will be the fraction ratio, which is unexcreted form. The erythromycin is 0.15. So we will calculate first Ku over Kn, and here is first of all 1 minus 0.15, 1 minus, and if we want to calculate the 10 ml per minute of the creatinine clearance, and our normal is 100 ml per minute, then we can check the Ku over Kn. This answer is, for example, 1 minus 10 by 100, this is 0.1, and 1 minus 0.1 is 0.9, 0.9 multiplied by 0.85, answer is almost 0.15 multiplied by its 0.85 multiplied by 0.9, it's 0.76. So our Ku over Kn value is 0.765. When we have the value of Ku over Kn is 0.765, and we want to check what will be its half-life is this particular patient is, then we can assume that the half-life will be increased. How it is increased? Because our Ku over Kn value is less than 1, and when we divide this 1 over Ku over Kn, then we can get the answer is 0.175. Yes, 0.765. So we will write here 1 divided by 0.765. This is equal to Kn over Ku. Remember, I have got the inverse of this, and same way when we divide the 1 divided by 0.765, answer is 1.370, and what will be the ratio of T half in the case of uremic over T half in the case of normal. So T half normal is, we have already known regarding from the table, that was 2. Then we can calculate T half is equal to 2 into 1.370, and our answer is, now its half life is 1.37 multiplied by 2, and it's 1.370 multiplied by 2.74. So its uremic half life is 2.74 hours of erythromycin. This is our actual concept. It means if we have decrease in the creatinine clearance, okay, how much decrease? We have assumed that 10% decrease. Only 10% drug is kidneys are performing. Then its half life is different. We can also calculate if we want to 20. We have the concept. Have the patient profile 20 ml per minute, and then we will divide this 20 divided by 100. Answer is 0.2. 1 minus 0.2. Answer is 0.8. 0.8 multiplied by 0.5. 0.85, and then we will get the answer and divide with the 1. After getting the dividing with the 1, then we will multiply with the half life, which is 2, or the half life will be changed from the normal one. As when we move toward the 30 ml per minute, 40 ml per minute, these are the so many examples when we are discussing this table. In this table we have the different drugs and their half-lives. For example, now we will want to discuss this concept in our clinical situation. For example, we visited the patient, and patient have their lab finding, and in lab finding it has the creatinine concentration. The physician has decided to check the creatinine concentration. Why they decided to check the creatinine concentration, serum creatinine concentration of the creatinine? Because they want to check the performance of the renal function, performance of the kidney, the concept of the clearance. Then if they found that there is some change of the change in the normal values of the creatinine concentration, we will first convert into the creatinine clearance. And if we assume that the creatinine clearance value is say 10 ml per minute, 30 ml per minute, 40 ml per minute, then we will divide with the normal one. And our normal one is 100 ml per minute. We have already know the for the adults, which is 108 ml per minute with the deviation of plus minus 20, and in case of female, in case of male, that was 120 plus minus 20, and in case of female, that was 108 plus minus 20. Then this is our normal one, and that creatinine clearance which we have calculated, and we know that if we know the concentration fraction of drug which is eliminated from the body unexcreted, then we can check this ratio, and this ratio will give us the dose adjustment. Okay, if we have the different dose, this ratio will be the less than 1, then when we want to check the dosage interval and half-life, that will have the same concept, the time. In case of dosage interval, we will get the more answer in the increased form, and in case of the half-life, we will also have the same direct effect of the increase of the half-life will be observed. Okay, these are the concepts regarding the half-life. If we can calculate the impact of half-life, if we found the half-life of the drug higher as compared to the routine one, it's normal, then we can assume that the same is the kidney function is also not performing well. Okay, how we would have to know the actual concept of this type of the calculations where we want to calculate? There are the 3 parameters I have already told you. First is we can change the dose, we can change the dosage interval, and we can change the both situations, dose as well as the dosage interval. This example will be which you have already which you have to follow. So the page number 793 in the Leon Chargel, that was the edition 7, and practical its problem, which was given us the concept of the how can we adjust the dose of the patients. Okay, scenario is, first of all, I will solve this equation, and then we will move toward the same concept which we have learned today. Okay, scenario is an adult male patient, and its age is 52 years and weight is 75 kg, whose serum creatinine concentration serum is 2.4 milligram per deciliter for a confirmed gram-negative infection. The usual dose of gentamicin in adult patient with the normal renal function is normal dose, we can write the DN, okay, that is 1 milligram per kg after 8 hours. After every 8 hours by IV bolus injections. Gentamicin sulfate is available, and this drug is available, gentamicin is available in 2 ml vials having 40 milligram. It means 40 milligram in 2 ml and 20 milligram per ml. Okay. What is the question? Question is, calculate the creatinine clearance in the patient by Cockcroft method. First of all, we have to calculate the creatinine clearance. Then, appropriate dosage regime of the gentamicin for this patient in milligram and ml. Okay, dose adjustment for this patient. Okay, this is a question, and from where we have to start? We have to start with because we know the creatinine concentration, serum creatinine concentration. First of all, we will convert this creatinine concentration into creatinine clearance by applying the Croft formula, and this formula is simple. We have already known creatinine clearance can be measured 140 minus age into weight divided by 72 into creatinine concentration in serum. This will give us creatinine clearance. When we found this creatinine clearance, then we can adjust the dose of the dose of that patient. Remember, be focused. Your target is first of all to categorize the patient. From which category the patient is. Either it's in the normal range of the creatinine clearance, or it is in some type of the renally compromised stage, stage 1, stage 2, stage 3, stage 4. Remember, I have already told when I give the lecture of the glomerular filtration rate, where we divided the creatinine clearance and the glomerular filtration rate. We have compared both, and we assume that these are the mild, moderate, and then the renally compromised, where the patient should be on the dialysis. So when we are discussing this, we have to put the values of age, weight, and then the creatinine concentration. The age we have already right here is, then it is 52, and weight is 75 kg, and creatinine concentration which is present in the serum plasma is 2.4 milligram per deciliter. Then when we solve this, we will got very simple, that is 38.19 milligram per ml. 38.19 milligram ml per minute, ml per minute. This concentration, this is creatinine concentration. Remember, our normal creatinine clearance is, if it is a male, then we can assume that normal is 120 ml per minute plus minus 20. It means it may be 100, it may be 140. It's a range, and we know normal creatinine clearance for the male is 120 plus minus 20. It may be ranges from 100 to 140 ml per minute. So now we know the creatinine clearance. We have the normal one, so we can check the ratio of the uremic patients, and by checking the concentrations of how much concentration is getting free in the patient, especially in the unchanged form, and the initial dose of the gentamicin sulfate of this patient may be estimated using the equation of the fraction of drug unabsorbed, and non-renal creatinine clearance is assumed to be 100 ml per minute. The fraction of dose excreted unchanged in the urine is, because we are discussing the gentamicin sulfate, and we will move toward this table and check the effect of the gentamicin. In case of gentamicin, we have gentamicin is 0.98. Its fraction value, fraction of the drug which is excreted unchanged, and we will write the formula Ku over Kn, that was equal to 1 minus Fe, okay, 1 minus creatinine clearance of the uremic patient, creatinine clearance of the normal, and this is our actual concept. The value of the gentamicin is 0.98. So when we write here 1 minus Fe, okay, that is 1 minus 0.98, and 1 minus creatinine uremic is, which we have calculated, 38.19, and divided with the normal, which we have assumed that it is 100. Okay, when we solve this, we will got the ratio. That ratio is Ku over Kn, rate of change of creatinine clearance with respect to time in uremic patient, and rate of change of creatinine clearance with respect to time in normal patient. when we get this ratio, this answer of this ratio is the very simple 0.39. Now, because it's a ratio, it has no units. So, Ku over Kn is 0.39. When we have the 0.39 is the Ku over Kn, now we can assume that, okay, is there any type of the change in the dose? Answer is yes, because we have to multiply this 0.39 with the normal dose. Normal dose was gentamicin, which we have already written 1 milligram per kg after 8 hours. When we per kg, it means for 75 kg, that answer is 75 milligram per kg after 8 hours. And when we are assuming that this milligram is this dose, we multiply this 75 because we have the 1 milligram per kg. Actual dose is 75 milligram after each 8 hours. This is actual dose, normal dose. And now we want to calculate the uremic dose. We will multiply this normal dose with the this ratio, and this ratio is Ku over Kn. Okay, when we multiply this 0.39 multiplied by 75, and our answer is 29.23 milligram after 8 hours. This is our dose for the uremic. Okay, we have the answer of this creatinine clearance by applying the Cockcroft formula, and then we have already calculated the dose adjustment for this patient. We have the three concepts. What is the focus we are discussing in this example is, if we want to adjust the dose, if we want to adjust the dosing interval, or we want to applying the both techniques. Now answer is, if we want to adjust the dose, then we can assume that we will give the minimum concentration of minimum amount 29.23 milligram after 8 hours. Remember, in 29.23 milligram means we have the injection of 40 milligram. We have the injection of 40 milligram. 40 milligram in how much volume? 2 ml. It means we have to reduce it 30 milligram. If 40 milligram of gentamicin sulfate is present in 2 ml, then how ml will be used for the 30 milligram? Then we will calculate. Okay, our answer is, if we have the 40 milligram in 2 ml, it means 20 milligram in 1 ml and 30 milligram in 1.5 ml. So we will give the 1.5 ml injection after 8 hours. The dose interval is now same. What we have calculated, the concept dose adjustment means we can have the three different areas. Okay, adjust the dose, okay, adjust the dosage interval, and third one is apply the both techniques. We will learn in this example the three all parameters. First of all, we have now at this stage, we have adjusted the dose. Our required dose is 29.3 milligram, 23 milligram, which can be rounded off to be 30 milligram. And 30 milligram drug will be present in the 1.5 ml of the injection. And we will give the same dosage interval 8 hours after 8 hours, but the dose is now not 2 ml wire injection, but it's 1.5 ml injection. Okay, what we will think about when we are discussing with the dosage interval? Now we will move towards once again our Ku over Kn. Remember, I have already told you Ku over Kn will be treated with the inverse. That will give us the dosage interval. Okay, we have the Ku over Kn 0.39, and if we want to calculate Kn over Ku, then we will have to divide with the 1 divided by 0.39. Okay, when we will divide this 1 divided by 0.39, then we will get the answer, that is 2.56. Okay, do it. For example, we are discussing now the second concept, adjust the dosage interval. Okay, how can we adjust? We will first calculate the Kn over Ku. that is 1 over 0.39, which is actually equal to dose interval of normal divided by dose interval of the uremic, dose interval of the normal, which is inverse. Remember, once again, we have to focus this. In case of dosage interval, the ratio is inverse. We will have to divide this 1.1 divided by 0.39. Answer is 2.56. Yes, 2.564. Now, what will be the dose interval of the normal? We will have to multiply this factor 2.564 multiplied by dose interval of normal, and dose interval of the normal drug was 8 hours. After every 8 hours, it means it was a TID. Then we will have to multiply this 8 with the 2.5684, and our answer is, now when we multiply this, we will get the 20.5 hours. 20.5 hours will be the dose interval of uremic patient. Our second technique, adjust the dose. When we are discussing the 20.5 hour, we will use the same injection of the 2 ml. Remember, we will not change the dose. We will just changing the dosage interval. And when we will change the dosage interval, we will assume that, okay, it's 20.5 hour. Then we will give a single injection per day. But in our routine cases, we were given the TID dose. So we have now prolonged the dose. Okay, our next concept, that concept is regarding the change, applying the both techniques. When we are applying the both technique, what are the techniques? Adjustment of dose. Another technique is adjustment of dosage interval. So we will calculate the passage between the both, because we want to maintain the therapeutic concentration of drug. Why we are maintaining the therapeutic concentration of drug? Because in our previous classes we have already understand the concept of the subtherapeutic, therapeutic, toxic, and the partially toxic and then toxic. Say when we assume that we want to maintain this drug into MEC and MTC. If we give the minimum dose, maybe it may lie there. Then we can assume that the drug is in the subtherapeutic range. So it will not give us some therapeutic values or some any type of the therapeutic effect. But when we want to adjust the both techniques, in the both techniques we will have to apply the concept of this dose. For example, the dose was, which we have already calculated, was 29.23 milligram. That was after 8 hours, and we can check the, okay, how much drug is in per hour. When, for example, in our according to this concept, we need 29.38 milligram per 8 hours. That was our concept. But in this concept, we have the 20.5 hour will be the dosage interval. Okay, what will be the situation in between? First of all, we will calculate the dose in milligram per hour. We know in case of 29.38 milligram per 8 hours, in 1 hour, what will be the concentration? Okay, when we assume that in 1 hour the concentration is changing both the maintenance dose and the dosage interval, using the dosing rate 29.25 milligram per 8 hours, our answer is 3.66 milligram per hour. We will divide this with the 8, and answer is 3.66 milligram per hour. Okay, this is our required therapeutic range which we need, 3.66 milligram per hour. And we will first, okay, move 3.66 milligram per hour and dose of the 23.9 milligram of every, and after what will be the after 6 hours? We will multiply with the 6, then we will get the 23.9 milligram every 6 hours, or 43 milligram every 12 hours will be produce the same average steady state plasma concentration. Okay, this way first of we will calculate milligram per hour, and then we will assume that the required dose is 3.6 milligram per hour. when we use this, say we use after 24 hours the same dose which was 40 milligram, and our concept is 40 milligram per 20.5 hour. Now we will calculate, our answer is 2 point, say when we divide with the 20, say we assume that 40 over 20, then answer is 2. So answer is 20 milligram per hour, 2 milligram per hour. In this case we have the 2 milligram per hour. In this case we have the 3.6 milligram per hour. So our condition is we can change the dosing interval, not 20 hours, not 8 hours. If we want to give it into 12 hours, then we can assume that we will multiply the same value with the 12, and then we will give the injection of the with the same which we have when we are calculating the 1 milli per 1 hour. Then we can calculate the okay for per 12 hours, and after getting the 12 hours we will multiply the same with the 12, and we will give the same dose, different dose of the different concept. Okay, this is actually the scenario of the concept of the dose adjustment. Okay, what about the half-life which we have started in our today's class? When we assume that if we have know the drug half-life of the gentamicin, we can assume that half-life of this patient will be increase or decrease? Increase. Why it is increased? Because we have the less creatinine clearance, and the relation with the half-life of the creatinine clearance is inverse. This is our actual concept. Okay, in another concept, we can also change this ratio into percentage. Okay, if we know the ratio, kidney is working, creatinine clearance is 25% of the normal, okay, 30% of the normal, 20% or 80% of the normal. What we are saying? We are saying that 20 by 100. We are saying that 30 by 100, 50 by 100. If the kidney function is 50% working, means normal creatinine clearance is 50% less as compared to the normal creatinine clearance. So we will divide this 50 divided by 100, and we will get this ratio. So this ratio will also give you another concept of the which are given in the Lyon charge in the table 24.7, where there are the simple 50%, 25%, 10%, and 0%, and they give with the effect of their extraction ratio, we can calculate, okay, what will be the percent of uremic patient overall elimination constant, means K or K in the percentages. These are all the actual concept of the effect of the different parameters. Thank you very much for this, and I hope you understand the actual concept of the effect of creatinine clearance or the clearance with the elimination half-life.